worried about the early repolarization, and I think the answer is no. I think the ascending, the ST segment elevation, early repolarization with an ascending limb, especially we see in young people and in athletes, I think is probably truly benign. I think they don't look like that. So I think we're not yet ready to make the diagnosis strictly based on an ECG. It's still a syndrome, and if you haven't had syncope or sudden death, I'm not sure you can diagnose it. But I think all those early repolarizations that we read on ECG are not all this.
Thank you, sir. I now request Dr. Narayana Swamy to felicitate our speaker, Dr. Martin Green. I request Dr. Martin Green to hand over the certificates to the chairpersons.
For the last session, I invite the chairpersons, Dr. Mahantesh, Professor of Cardiology, KIMS, Bangalore, Dr. J.C. Adiga, Consultant Physician at Puttur, and Dr. Syed, Consultant Interventional Cardiologist at Father Muller's, Mangalore. Kindly take your seats. I invite Dr. Shashidhar, our speaker, onto the dais to speak on pre-excitation syndromes. I request the chairpersons to introduce Dr. Shashidhar.
Good evening. Dr. Shashidhar is a well-known electrophysiologist in Karnataka and is currently working in Fortis Hospital. Earlier, he was associated with various corporate hospitals like Narayana Hrudayalaya and Manipal. So I request Dr. Shashidhar to deliver his lecture.
Thank you, Chairman. After a fantastic talk by Dr. Martin Green about not so common arrhythmias, probably we'll come to now more common pre-excitation syndromes. Before going into the pre-excitation syndrome, I would like to spend some time with this ECG. I think by this time you all know what is this ECG shows. The point of putting this ECG is whenever I see a patient with a wide QRS, this is a 12-lead ECG, the most obvious thing is wide QRS. When there is a wide QRS, always look for a PR interval. You look at the ECG, PR interval is short, and if you look closely at the QRS complex, the initial part of the QRS complex is slurred. So there is a delta wave. So short PR, delta wave, wide QRS, you have a pre-excitation there. Why does this pre-excitation occur? So this is a mechanism of pre-excitation. You know, there is an accessory connection, which is a muscular connection, which is usually situated along the atrioventricular valves. So there is a simultaneous conduction to the ventricles through the AV node as well as through the accessory pathway. The part of the ventricle which is activated by the accessory pathway is activated ahead of its time. That's why it is called pre-excitation. Since it bypasses the AV node, there is a short PR interval. And the conduction is slow because it is occurring through the ventricular muscle, so there is a wider QRS. So you have a short PR, wide QRS, and a delta wave, which says it's a pre-excitation ECG. If this patient presents with a history of tachyarrhythmias, then we say it is a pre-excitation syndrome or WPW syndrome. WPW syndrome was described by this gentleman. It was way back in 1930, a series of 11 patients who had short PR, wide QRS, and paroxysms of SVT. That's how it was described. So as I told you, the pre-excitation is because of a presence of an accessory pathway, which is a muscular connection which is situated along the atrioventricular groove, usually. This pathway can conduct anterogradely, that is from above downwards, from the atria to the ventricle, or from below upwards, that is retrograde, from ventricle to the atria. So there are two types of ECGs possible with the accessory pathway. This is a manifest bypass tract. So whenever there is a conduction through the accessory pathway as well as through the AV node, there is a shortening of the PR interval, delta wave, wide QRS, that says there is a pre-excitation in the ECG. So this is a manifest bypass tract. These manifest bypass tracts, most of the time they conduct retrogradely also. There is a situation where the pathway conducts only retrogradely. It doesn't conduct anterograde. So there is no evidence of pre-excitation in the ECG. PR interval is normal, QRS is normal. So this is something called concealed bypass tract. So there are two ways. One is a manifest bypass tract and the other one is a concealed bypass tract. There are three types of tachycardia with this kind of a pathways possible. One is orthodromic reentrant tachycardia. That is, the circuit is like what is shown in the upper diagram. It activates the ventricle through the normal conduction system, AV node, bundle branches and His Purkinje system, and then back to the atria through the axillary pathway. So the activation of the ventricle is through the normal conduction system, so QRS is narrow. Okay, you don't have any evidence of a widening of the QRS. This is a common occurring orthodromic reentrant tachycardia. The other tachycardia which is possible is antidromic tachycardia. Whenever the conduction occurs antegradally through the axillary pathway down to the ventricle. So the QRS is wide. It can be regular or it can be like this. It's a fast, broad, irregular tachycardia. When a patient has atrial fibrillation, it can conduct down the axillary pathway and then produce a ECG like this, fast, broad, irregular, complex. So this is a pre-excited ECG. So all these three types of tachycardias are possible with the axillary pathway. And most of the time, this can degenerate into ventricular fibrillation and give rise to sudden cardiac death. Coming to what are the types of axillary pathways. As I told you, these axillary pathways are situated across the atrioventricular valves. If you can see the diagram there, this is the atriofascicular, starting from the atria attached to the fascicle. Atriofascicle, also known as the Maheim's fibers. The other one is nodoventricular, nodofascicular, and of course atrioventricular. So the commonest is atrioventricular, what we see in a day-to-day practice. The other pathways are less common. Pre-excitation syndrome usually occurs in a normal heart most of the time, but 10% of the time it can associate with the abnormal heart, especially Epstein's valves. There are other conditions like mitral valve prolapse and ASD, VSD, CTGA also can be associated with the pathways, axillary pathways. The prevalence is in the range of 0.2 to 0.3%, and it can occur as a familial form also. So how do we locate the bypass tracts? I told you the bypass tracts are usually situated along the atrioventricular valves, that is the mitral valve and the tricuspid valve. This diagram shows the cross section at the base of the heart. This is a tricuspid valve, mitral valve, there is an aortic valve and the pulmonary valve. And there is a coronary sinus encircling the mitral valve. So pathways are usually situated along the tricuspid valve or along the mitral valve, along the base. Very rarely they are not seen in the trigonal area, which is shown in the picture. So how do we locate based on the ECG, the location of the pathways? Location of the pathways is important for an electrophysiologist to approach the pathway during ablation. For a clinician, it is usually a good exercise to know whether it is a right-sided pathway or a left-sided pathway. Otherwise, prognostically, it doesn't give any much importance. So the location of the pathway is based mainly on the polarity of the delta wave. So here is shown the initial 20 to 40 milliseconds of the initial QRS complex is taken. So here the upslope is positive, so it's a positive delta wave. When it is negative, initial 20 to 40 milliseconds is negative, it's a negative delta wave. And when it is equiphasic, positive and negative is that it is isoelectric. So these three polarities are important to know to locate the pathway. So how do we know whether it is right sided or left sided? So as I told you, it's usually first 20 to 40 milliseconds of the delta wave you should analyze. And usually the QRS follows the delta wave polarity. If delta wave is negative, QRS also will be negative. And primary concerns for a physician should be whether it is a right sided pathway or a left sided pathway. So most probably, if you look at the lead V1, if it is positive, the R wave is taller than S wave, it is definitely a left sided pathway. Suppose if it is negative, then probably you are looking at a septal pathway or a right sided pathway. The other thing is leads 1 and AVL. They are very important. Suppose the lead 1 and AVL, the vector is moving towards 1 and AVL, it is always produces a positive deflection, whereas the vector moving away from 1 and AVL is a negative deflection. So if it is a negative in 1 and AVL, it is definitely a left-sided pathway. It's a left prevalve pathway probably. If it is positive, either it is a septal or a right-sided pathway. Then it depends on whether it is located anteriorly or the posterior part of the valve. Then you will have to look at the leads, inferior leads, 2, 3 AVF. If the polarity of the delta wave is positive in inferior leads, then it is coming towards the inferior leads, that is anterior. Suppose if it is negative, that is it is going away from the inferior leads, so it is posterior. So looking at the polarity, you can make whether it is an anterior location or a posterior location. Other thing is a V-lead transition. That is, you look at the precordial leads, there is an early transition from negative to positive becomes, that is a transition. So if there is an early transition, probably that says it is a septal location. This is one of the commonly used algorithms by Aroda et al. Briefly, I will go through this thing. Basically, they looked at 2 leads, the lead V1, lead 1 and AVL. If look at the lead V1, one is ECG, if the R wave is positive, if it is more than S wave, and then look at the lead 1. Lead 1 is either positive, either it is negative or it is biphasic, that is equiphasic, isoelectric, then you are dealing with a left-sided pathway. So lead V1 is important. Once the lead V1 you say a positive R wave, look at the lead 1. Lead 1 is negative or it is equiphasic, that is isoelectric, you are looking at a left-sided pathway. Suppose if the lead V1 is negative or if it is isoelectric, then it could be a septal or it could be, usually it is a septal location. And then look at the V1 if it is positive. V1 is positive, but it is, the R wave is not more than S wave. R wave is less, but still if there is a positive wave, it is a right-sided location. So this is mainly based on the Brugada's location, Brugada's criteria. The main thing here I want to tell you is, it is important to know whether it is right side or left side. Anterior, posterior, septal, lateral is not important for a clinician. Then pre-excitation syndrome, one of the problem is a sudden death. Incidence of sudden death is in the range of 0.15 to 0.39% over a follow-up period of 3 to 10 years in one study. How do you find out the patients who are at risk of sudden cardiac death? If you look at a patient who presents with a fast, broad, irregular tachycardia, that is the AF conducting over the axillary pathway, you look at the shortest RR interval. If it is less than 250 milliseconds, that is indication that the patient is at the risk of sudden cardiac death. Other features suggesting that a patient is at the risk of sudden cardiac death is multiple pathways. If a patient has underlying structural heart disease like Epstein's anomaly, or if a familial history is there, that is also a risk factor for a sudden cardiac death. This is how we can risk stratify a patient presenting with a pre-excited ECG. Then who are the patients who are at low risk of sudden cardiac death? If you see a patient with the ECG shows some beats show pre-excitation, some beats are normal, then that means the conduction through the pathway is very sluggish. It blocks at a little bit higher rate. So that means it is a safer pathway. It cannot conduct faster enough to produce ventricular fibrillation. Other thing, as I told you, is a RR interval in a pre-excited AF. If it is more than 270 milliseconds, probably the chance of having a sudden cardiac death is less. Then other way of risk stratifying is stressing the patient. You stress a patient, suppose during the exercise the pre-excitation disappears, that also says the pathway is definitely, the patient is not at the risk of sudden cardiac death. So coming to the treatment part. So, I already showed you the 3 possible arrhythmias. One is orthodromic tachycardia, that is a narrow QRS, regular narrow QRS tachycardia. When you encounter such a patient, it should be either vagal maneuvers or IV adenosine is a treatment of choice. If it is an antidromic tachycardia or a pre-excited AF, it's a wide QRS tachycardia. The best thing to do if the patient is unstable, definitely you are going to do cardioversion. Even otherwise, in Indian context, it is better to do a cardioversion because we don't have a drugs which act solely on the axillary pathway. Otherwise, probably you can give procainamide or flecainide, which acts solely on the axillary pathway. What about the long-term treatment? Long-term treatment, with a patient with a pre-excited ECG and tachycardia, probably you can use class 1C drugs. Flecainide is available. Sotalol is there. Sotalol is a class 3 drug. And class 3 drugs are more useful in presence of structural heart disease. Otherwise, class 1C drugs are the drugs of choice. You can always combine them with the beta blockers to reduce the conduction through the AV nodes. One important point here is a patient with a pre-excited ECG has a history of tachycardia, don't use calcium channel blockers or digoxin. They can accelerate the conduction over the axillary pathway and can predispose the patient to sudden cardiac death. That is very important. Other thing is catheter ablation. Nowadays, the radiofrequency ablation is a preferred treatment for a patient who has already had a symptomatic arrhythmias. The success rate is usually in the range of 95 to 99%. It's quite effective, quite safe. Mainly, it's a radiofrequency energy. Even cryoablation also can be used, especially when the location of the pathway is closer to the AV node, where there is a risk of producing damage to the AV node. This is one of the patient where they had a pre-excitation. You can see the arrow marks, the clear-cut short PR interval delta wave on the ECG, especially in the precardial leads. And this is the tachycardia which is induced in the lab. It's a regular narrow QRS tachycardia. And this is a schematic representation of the placement of the catheters. One is in the RV, the other one is in the RA, and 10-pole catheter is in the coronary sinus, the other catheter is near the His bundle. This is usually the classical placement of catheters in an electrophysiology study. And this is the fluoroscopic image of the same patient where he had an axillary pathway located in the left anterior location. This is the mitral valve, near mitral valve, left anterior location. And if you can see here, where we started the ablation here, it is indicated by a sharp deflection here. Third bit, the deflection of this delta wave has disappeared. So the radiofrequency ablation is quite effective in treating pre-excitation syndromes. What do we do with the asymptomatic individuals? You come across a patient, you detect there is a short PR, there is a delta wave, wide QRS, but he doesn't give any history of palpitation at all, completely asymptomatic. Do we subject them for an electrophysiology study? Do we ablate them? Do we offer them ablation? So it depends. You will have to risk stratify the patients. As I told you earlier, there are ways to risk stratify. Electrophysiology study is important. Suppose if a patient is in a high-risk profession, like pilot or a driver of a public transport systems, or a person who is in the military, who medical grade can be degraded because of presence of a pre-excitation, such patients probably we can offer radiofrequency ablation. Otherwise, those who have a feature suggesting high risk for a sudden cardiac death, that pathway conducts very rapidly. You can always do a treadmill test in them, see for the disappearance of the pathway. Pathway doesn't disappear, persists at a higher rate. Probably he has to subject it for an electrophysiology study. So coming to the conclusion, pre-excitation, as of my previous speaker clearly told, Dr. Ash Logan, it can be mistaken for a bundle branch block and for a myocardial infarction also. Whenever you see a fast, broad, irregular tachycardia, your diagnosis should be AF with conduction over a bypass tract, and the treatment of choice is cardioversion. And a patient who presents with a pre-excited ECG, always risk stratify, whether he is at risk of sudden cardiac death or not, that you should always work out. Catheter ablation is safe and effective in symptomatic individuals and those who are at risk of sudden cardiac death. Thank you.
Thank you very much for the excellent talk. Because of the shortage of time, we can take one or two questions from the audience.
In the chapter of risk stratification in WPW, there is a group of patients which the textbooks describe. Patient is asymptomatic, ECG is normal, but you find a path. So, and they say that such patients are at low risk. I don't understand. I mean,
no, you said ECG is normal.
ECG is normal, patient is asymptomatic, and still you find a path.
No, how do you find a pathway there?
I don't know. That's what because it is in the Topol's book.
No.
And they say that these patients are low risk. And why did they go to find the path in the first place? When is
intermittent pregnancy. Suppose if you mean like ECG looks normal sometimes, and some bits say there shows the presence of an axillary pathway, then that itself shows that it is a low risk category because the pathway is conducting very slow. At a little bit higher rate, it disappears. It doesn't conduct.
No. What I was wondering, the patient is asymptomatic, ECG is normal. Why did they go to find the path in that manner? Yes, sir. Yes, Lokandwala. I want. Okay.
Sir, I have one question here. Sir, here.
Sorry.
Sir, among the pre-exciting syndrome, what is the role of LGL? Number one question. Second question is
LGL.
LGL.
Okay.
Second question is when the patients have neonatal arrhythmia, especially pre-exciting syndrome, where the endoplasmic reticulum is not developed fully, what is the drug of choice used for those neonatal arrhythmias?
Okay. So your first question, LGL syndrome, lone gonangular vein syndrome, what we say is ECG shows there is a short PR interval, otherwise QRS is normal. There is no evidence of pre-excitation. And these patients usually do not have any tachyarrhythmias. It doesn't support the tachycardia. This is probably because of the presence of a pathway which directly inserts into the His bundle. So clinically it doesn't have any significance except that PR is short. As of second question about your infantile arrhythmias, it depends on what kind of arrhythmia the infant is having. If it is a narrow QRS tachycardia, in the absence of if it is not a wide QRS, it should be treated like any regular narrow QRS tachycardia. If it is a wide QRS tachycardia, then probably you will have to prefer drugs like flecainide, which can act on the accessory pathway. It can be used safely in doing pregnancy also, flecainide.
Can we use digoxin and verapamil because of the...
Digoxin and verapamil, if it is a narrow QRS tachycardia, maybe yes, definitely you can use.
Because
Suppose if it is a wide QRS tachycardia, never use calcium channel blockers or digoxin.
No, in narrow complex tachycardia, we can use in the infants because of the underdevelopment of this problem.
Yeah.
For patients below 1 year of age, calcium antagonists are not preferred.
Yes.
The drug of choice is adenosine for acute termination,
Yeah.
digoxin and propranolol, Inderal, and not calcium antagonists, because some of these patients go into severe low output state for the very same reason that you said, that they don't have a developed calcium endoplasmic reticulum system.
Thank you, sir.
One more question, Dr. Shishir.
Yeah.
And what is the recurrence rate after the EPS and RFA? And is there any role of surgery in the refractory cases?
Recurrence rate depends on the location of the pathway also. The recurrence rate is quite less for left V wall pathways. It is more common with the right side pathways, and for the septal pathway the recurrence rate is slightly higher. But all this recurrence is in the range of 2 to 3%. It should not be more than that.